decades. And we bring this podcast to bring into limelight the complex terminologies which are come into practice with this hospital-acquired infections. And there are so many new budding microbiologists who are coming into this field, fail to understand these terminologies. So I would request Dr. Ankit to just put a limelight on these complex terminologies and make us understand how he uses his methodologies of doing hospital acquired infections, and why it has become so much mandatory to be a to do this hospital acquired infection in this corporate hospital settings. Up to you, Dr. Ankit. You can start, please.
Thank you, sir. So, good afternoon, everyone. So, it's a pleasure.
And we bring this podcast to bring into limelight the complex terminologies which are come into practice with this hospital acquired infections. And there are so many new budding microbiologists who are coming into this field, fail to understand these terminologies. So I would request Dr. Ankit to just put a limelight on these complex terminologies and make us understand how he uses his methodologies of doing hospital acquired infections, and why it has become so much mandatory to be a to do this hospital acquired infection in this corporate hospital settings. Up to you, Dr. Ankit. You can start, please.
Thank you, sir. So, good afternoon, everyone. So, it's a pleasure to be interacting with all my fellow microbiologists, whether budding, as Dr. Raman said, or the senior ones, or my colleagues. So, today we are not going to discuss about how to diagnose a healthcare associated infection, but we will delve softly about what is HCAI. So, my friends, the concept is very simple. Every infection which occurs in a hospital is not healthcare associated infection. Okay, let me repeat, sir. Every infection which occurs in hospital is not a healthcare associated infection. So if many people would raise their eyebrows, why, how is it so? So now that brings us to a difference between what is HCI and what is a community acquired infection. So, sir, as we all know that infection and microbiology, these are two synonymous terms. Every patient who has a fever, who has a raised abnormal, like say blood parameters, raised TLC, raised CRP, procal, and any of the culture is positive, any clinician would label it as a healthcare associated infection. But sometimes we fail to differentiate that in the majority of people who get admitted to a hospital, they are already suffering from certain disease, be it via gastrointestinal, bloodborne, respiratory system. So those infections are called as community-acquired infection. So it is very, very essential to differentiate between a community-acquired infection and a healthcare-associated infection so that they can be diagnosed and treated accordingly.
Okay. At this point, Dr. Ankit, I would like to stop you. Suppose a patient lands up in the hospital with H1N1.
Yes,
Uh,
sir.
but he at this present he is not showing any positive but for H1N1. But while in the hospital, maybe after 2 days of admission, you find that his H1N1 is positive. Will it still remain a community acquired, or will we call it as a hospital acquired infection in this case?
Thank you, sir. So, sir, in this case, you have brought out a very important topic, which is a second dimension of healthcare associated infection, which is called as an outbreak. Like I earlier mentioned, community acquired infection, healthcare associated infections are different in terms of the type of microorganisms, if from which they are caused. Like in the case you spoke about, a patient who was already having some symptoms of upper respiratory tract, he came to hospital with a positive diagnosis of influenza. Now, in an unfortunate circumstance, if a patient is admitted in a general room, which is being shared by other people who are not having a respiratory infection, there are very, very high chances that other people may also acquire the same infection as a H1N1. So we can see a evolution of a community acquired H1N1 into a full blown H1N1 outbreak in a particular hospital setting. So here the attention will shift from a healthcare associated infection to an outbreak which is even a higher level of intervention that a IPC or infection prevention control expert should do in the respective healthcare hospital.
Okay, that's good. Okay, I just spoke about some complex terminologies, which I think infection control spectrum has already been in practice. So, what are those complex terminologies, and why they're so complex, and why can't we keep them simple for us to easily understand all this?
Sir, on a lighter note, the complex terminologies, they lie in the name of the bacteria. Like if I tell you to utter a word, something called as Crysiobacterium meningosepticum, you will say, leave it, yeah, this is a gram-negative infection. What I have to do with the names. Sir, in microbiology, these terms are difficult, but they should be understood so as to differentiate between a community-acquired infection and HAI with. So, sir, some of these terms, the first term is comes to our mind is a surveillance. Now, once we talk about surveillance, surveillance is a mechanism by which we keep a record of many activities and it's an ongoing activity. So, surveillance is one complex term. Second term is date of infection. Date of event. Date of event means whatever infection we are tracking or whatever infection we are classifying it as HAI, the symptoms or the test should follow a certain date. Then second term is the third term is infectivity window period, which means that beyond a certain time, a healthcare associated infection should not be tracked. Fourth term, sometimes the obvious use is a repeat infectivity time frame, in which once we have diagnosed one HCI, we do not diagnose it again so that the hospital surveillance definitions are not messed up. So these four terms are the complex ones, but I hope we would be able to simplify them for our microbiologists. So surveillance, date of event, infectivity window period, repeat infectivity time frame, and last but not the least, these HCAIs or healthcare associated infections, they follow a certain definition. So these definitions are usually derived from CDC, that is Centers for Disease Control, or NHSN. Gradually and slowly, even India is also coming up with their own definitions, and within a span of no time, we might be having those versions or definitions which are more suitable in the Indian context or Indian population.
Okay. Dr. Ankit, you might have finished your microbiology around 16 to 17 years back. So, as much my understanding in your curriculum, infection control, being infection control specialist is a part of the curriculum, but not really as I'll say practically you're never exposed to do how to do it. So, when you landed up in a corporate hospital, so what are the steps did you take to become to reach to a platform where you can easily control this infection control specialty as being an infection control specialist? So what are the things, what did you do? And because this will actually enlighten our new budding microbiologists who are new to this field, they'll be able to understand how to move about. And can you just enlighten us on this?
Yes, sir. So probably 1.5 to 2 decades back when I completed my microbiology, the terms of quality, safety, accreditation, surveillance, these were heard, but they were not into actual practice. So when the day I completed my MD microbiology and landed up in a hospital, it was as if I knew nothing. Because during our post-graduation days, we were taught more about the ways of interpreting a culture, more about the theoretical aspect. Once we enter into a hospital, we are supposed to exert our clinical knowledge also. That is what we have acquired. So first of all, the first step that I took was not the step, but the steps. Every day was dedicated to a different area of the hospital. Let's say, so I tried to divide my hospital into two broad areas, a clinical area and a support area. A clinical area was the one in which a patient was admitted, was being treated by a various team of healthcare workers. And second was a support area in which the patients were being offered the environment in which they are being treated, which includes kitchen, which includes engineering. What I used to do, I after spending my time in the lab, once the reports were out, everything was done. I used to visit 2 to 3 clinical areas and 2 to 3 support areas to have an understanding what are the possible areas where a patient would get infection. Now, if we talk about clinical area, the clinical areas are many in a hospital. It can be an ICU where our sick and moribund patients are admitted. It can be an inpatient department where so far healthy to not so sick patients are admitted. Then there is an OPD where patients are coming up for the clinical diagnosis by the physicians. And fourth are the areas where patients are coming for, let's say, vaccination or surgeries. Gradually, I understood that what practice I can implement in ICU may not be the same in IPD, may not be same in the OPD, but may not be same in the other areas. But few practices are common to certain areas, few are uncommon. Let's say hand hygiene, common to all. Biomedical waste management, common to all. Uh, Appropriate use of personal protections, common to all. But cleaning, more in ICU, then IPD, then OPD, then the other areas. This was a segregation of clinical areas which was happening in my mind. Now, sir, as a microbiologist, as a doctor, we fail to understand that even the air a patient is breathing, the food the patient is eating, or the water the patient is drinking, that can also be a source of infection to a patient. I also ensured I was sitting together with my few non-clinical heads, that is the head of engineering, the head of housekeeping, the head of F&B, the head of CSSG, the head of stores, so as to understand what contribution I can have from them to have a meaningful infection prevention and control program. So that was my journey. And during that time, the NABH was already in picture. So they also have also started with the surveillance definitions that when I started, we were usually taught about a nosocomial infection. Now, nosocomial infection went on to hospital acquired infection. Now it is called as a healthcare associated infection. So this was one thing. Second, I also put my focus on the various cadres of healthcare professions. A healthcare profession include a doctor, a nurse, an administrator, a general duty assistant, a housekeeping personnel, and everybody should be taught about certain practices. Now, with the same practice, we cannot teach a doctor same as a housekeeping person. So I tried to make my topics relevant for the activity a healthcare personnel is doing, so that we can sensitize them. And so at the end of the day, it is all a team approach which actually translates into a infection control and prevention program for the hospital. So far has been my journey. And for the journey, I would urge all my microbiologists to please step out of the lab, step out of your comfort zone, and see the areas of the hospital which you have never visited. You will find certain scope of learning there.
Okay, good. Dr. Ankit, many times now our surgeons keep on talking, this is a clean OT, this is not a non-clean OT. So, matlab, we always believe every OT should be clean. Why they use the term non-clean OT or a clean OT? Can you just let us know what is this clean OT and non-clinical OT? Is there some term or is just a very vague term which is being used? Uh,
That all OTs are clean.
okay.
Only the kind of cases are done in an OT can be clean, can be contaminated, can be clean but not contaminated, can be a dirty. So the OT atmosphere will remain the same whether we are doing a cardiac transplant or we are just putting up a suture. The whole idea is if the environment becomes more dirty during an operation, the OT might need a more round of extensive maintenance after a certain surgery. For certain complex surgeries, we may need to put up additional measures so as to ensure that OT is clean. But nonetheless, every OT is clean. Every OT is clean.
Okay. And initially, because now when we were very junior pathologists, we used to get staff from the OT that they wanted formalin to do fumigation. Is it still a practice, or it's become a old practice now?
Well, again, I would say a few practices they still stay. So, sir, for some of the senior people, fogging is like an activity which has been etched in stone. So, sir, now fogging is usually not recommended. Rather, to say that formalin as a method of fogging has been discouraged for a lot many times. If we go into the details, NABH, that is a National Accreditation Board of Healthcare Providers, 6th edition, they specifically mentioned that routine fogging is not necessary in an in any area. They recommend fogging in two or three conditions wherein there has been a new construction activity in an area, there has been certain renovation, or there has been a particular trend of healthcare associated infection due to multi-drug resistant pathogens. Because fogging does not offer any additional advantage over the routine practices. If routine practices are being done, fogging is an additional step. But routine practices, if they are not done, that is housekeeping, change of linen, and other practices, then fogging mostly remains an eyelash.
Okay, good. And and have you been practicing doing a culture of the air, culture of the and or what all cultures do you take from the OT? Just curiosity, I'm asking, what all cultures do you prefer to take?
Then this is a kind of question which I hear from every single day. The moment I walk into any clinical area, everybody says, take this culture, take this culture. So I have stopped going to OT with swabs in my pocket. So, sir, routinely, even environmental cultures are not routinely recommended. But if they at all needs to be taken, we can take air cultures, we can take water cultures, we can take cultures of the contaminated areas, but they should be done only to ascertain that whether there can be any chain of infection or any uh, anything that we have missed during a emergence of a healthcare associated infection and outbreak in a hospital. If I have to sum up, fogging and surveillance cultures are not routinely recommended. So there has been evolving consensus with these surveillance cultures and fogging. And sir, these few things have stood the test of the time, and few things are evolving and ongoing. So let's hope what lies next for us as a microbiologist.
Good. And Dr. Ankit, there was one which episode which I heard maybe around 10-15 years back. A case of gas gangrene was operated inside an OT, and there were only two functional OTs in that hospital. And the surgeon said now he cannot take case in that OT because gas gangrene has already been opened up, or maybe whatever the debridement was done in that case. So they said we are not going to take up any case in this. Is it true, or is it what according to you should have been the best practice?
According to me, if there is any surgery which is an emergent, then all the cases should happen within a defined frame of time. But what we need to ensure that between two cases, an appropriate time is provided for the entire cleaning of the OT theater. During an operation, the traffic in the OT is minimized to the extent possible. All the people who are involved in the surgery, they should only participate or go inside the OT, keeping the traffic to the minimum. And a lot is also attributable to the engineering of the OT, that is includes installation of a HEPA filter, OT ducts, ACs, temperature, humidity. If all these things are pretty much in place, to the best of my knowledge, we can do cases. But if there is something which a surgeon would like to discuss, this can be discussed between the respective teams and an appropriate solution can be worked into so that we do not compromise onto the patient safety and patient quality.
Okay. And one more thing, as you know, because from a microbiologist to infection control specialist, we don't have uh, any agencies or any accreditation bodies who are accrediting you to become an infection control specialist. So, have you planned to start something which empowers a microbiologist and maybe guides him better way to become an infection control specialist? What's your take on this?
My take would be that a very interesting question, sir. Uh, 1 or 2 seconds more, if you allow me some time.
Yeah, please.
My journey has been of a journey of learning, failing, learning again, and then standing up. What I have understood that during the course of my journey, please do not be fearful of experimenting, but experiment only based on the published literature. So what I have in mind that why don't we share the stories of microbiologists like me to our budding people, the difficulties we encountered, the solutions we got, the kind of challenges we faced, the kind of potential problems we got, so as to we can convert the knowledge into real case-based scenarios. And what I have learned best is with the case-based scenario rather than with a didactic knowledge. When I became an microbiologist, I did not knew the steps of hand hygiene. But once I remembered it, I think even if someone wakes me in the middle of the night, I will just start rubbing my hands. So we should understand what we don't know. We should understand what we should know. And let's be an open interaction with all kinds of clinicians. And more it appropriate would be a real case-based exercise rather than a theoretical and demonstrations.
Thank you, Dr. Ankit. And thanks for being with us. And this podcast of us will be aired on our YouTube channel, which is Pathology Mentor. And it will be also available on the site. And thanks for joining in.
Glad to be a part of it. And what an auspicious day than the Independence Day. So, like we got away from the clutches of slavery. So, hope we can envisage a day wherein all the microbiologists can contain all the healthcare associated infections in terms of patient safety and patient quality. And it was a lovely experience and the privilege to be a part of this podcast with you, Doctor. Thank you so much.
Thank you very much.